Hello everyone and welcome to Ovarian Cancer Australia's Information and Support webinar. My name is Vanessa Alford. I'm part of the support team at OCA. I'd like to begin by acknowledging the traditional owners of the land that we're on and pay my respect to elders past and present. I'd also like to acknowledge and thank Telematics for providing us with the funding to deliver this webinar. The focus of this webinar will be on the latest updates in ovarian cancer. We have three incredible presenters who are going to share some valuable information with you. The webinar is interactive, so over the next hour you can ask questions to the presenters by typing into the chat box at the bottom left-hand corner of your screen. Questions will be answered at the end of each speaker's presentation. Please note that presenters cannot address individual medical cases. If you have a particular question, please call the Ovarian Cancer Australia Information and Support line on 1300 664 334. This webinar is being recorded and will be posted on the Ovarian Cancer Australia website at the conclusion of the webinar. If you're having trouble with the sound, you can dial the 1800 number listed in the chat box. We could just go to the next slide. So I'm extremely privileged to introduce our presenters to you. Our first presenter is Dr. Yoland Antill. Dr. Antill is a medical oncologist and cancer genetics specialist at Frankston Hospital, the Royal Melbourne Hospital and Breeding Health in Melbourne. Her interests are in the management of breast and gynecological cancers. Dr. Antill is involved in the development and conduct of clinical trials and has published over 30 papers in international journals. She has more than 15 years' experience in both medical oncology and in the diagnosis and management of hereditary cancer syndromes. Dr. Antill will talk about some of the current research in ovarian cancer, including the SOLO-2 trial, looking at the use of Olaparib in early ovarian cancer. Our second presenter is Dr. Tarek Meniawy. Dr. Meniawy is a medical oncologist who subspecialises in gynecological cancers and who holds consultant appointments at St Charles Gardner Hospital, the King Edward Memorial Hospital, and St John of God Physiatric Hospital in WA. Dr. Meniawy will talk about clinical trials and new therapies in ovarian cancer, including PARP inhibitors, immunotherapy, and the timing of different treatments. And our final speaker is Ms. Vicki Sidoti. Vicki was diagnosed with stage 4 ovarian cancer 5 years ago at the age of 54. She has three children and 9 grandchildren. She's undergone surgery and chemotherapy to treat her ovarian cancer, and she was part of a clinical trial for Olaparib. Vicki, who will be joined by her lovely daughter Angela, will share her experience of being on a clinical trial and why the trial was so important to her. So I'd now like to hand over to Dr. Yoland Antill.
Hello everybody, and welcome to the webinar. I am a medical oncologist and a cancer genetics specialist, and it's a privilege to talk to you tonight about some of the latest developments in ovarian cancer, and in particular how Australia is really helping lead the way in understanding the background and translating that background scientific research into how we can change the face of ovarian cancer forever. So the vast majority of the talk is going to be based on an understanding of what we know as epithelial ovarian cancer. There are 3 different types of main ovarian cancer, and epithelial is by far and away the most common. But even within epithelial ovarian cancer, there are a number of different types of ovarian cancer, and we're going to focus in on some of those more rarer or subtle subtypes. Dr. Tarek is going to take you through the more common treatments for the more common high-grade epithelial ovarian cancers. So I thought we would take this opportunity to talk about some of the more unusual or uncommon types of ovarian cancer. So most epithelial ovarian cancer has traditionally been treated with chemotherapy, and the backbone of chemotherapy in ovarian cancer is platinum-based. But there is much discussion now over the role of something called intraperitoneal chemotherapy versus intravenous chemotherapy. Intraperitoneal chemotherapy is given at the time of your surgery, where the chemotherapy is actually bathed around the abdominal cavity at the time of your surgery. This is given at the time of your surgery and then is followed by intravenous chemotherapy. In some of the research that has been done, the intravenous chemotherapy is given for a number of cycles prior to the surgery, and then the surgery takes place with what's called the debulking or removing of the ovaries, the fallopian tubes, and the uterus or womb, as well as any other sites of ovarian cancer that the surgeon can see. This would be followed by bathing the remainder of the abdominal and pelvic cavity in chemotherapy that has either been warmed or at normal room temperature. Some of the latest developments in the treatment of epithelial ovarian cancer is in immune therapies, and Dr. Tarek again is going to take you through lots of those changes. I want to focus on a very rare type of ovarian cancer called the mucinous ovarian cancer. So this is probably the least common type of ovarian cancer and really varies from very low grade and very low growing cancers to very fast, very rapid and very aggressive type of cancer. Until very recently, it was thought that the low grade was not actually related to high grade mucinous ovarian cancer, or even that high grade mucinous ovarian cancer may have actually arisen in other sites in the body, such as the stomach or even the bowel. So Australian scientists led by Kylie Gorringe and our team have forged collaborations with many other sites around the world, including North America and the United Kingdom, to collect samples from 300 women who had mucinous ovarian cancer. These ranged from pre-invasive through to the very high-grade ovarian cancer, and some very exciting discoveries have been made as a result of these very extensive body of work. One is that there really is a continuum between low grade through to high grade, and even prior to the low grade invasive, what we call borderline ovarian cancer. We have been able to identify a number of what's called targets, so a number of changes that occur in the genetic makeup of the tumour that could potentially be targeted, and we're going to take forward these works in the near future, hopefully within some clinical trials. Very importantly, mucinous ovarian cancer is very different from the majority of ovarian cancers in that platinum-based chemotherapy is relatively ineffective in the vast majority of these cases. And as such, the PARP inhibitors that are used in the setting of high-grade serous ovarian cancer is ineffective here. In addition, it appears that immunotherapy is unlikely to have a significant role in the treatment of mucinous ovarian cancer. However, with all the trials that have been conducted and the number of changes that have been found, it is thought that about 80% of women with mucinous ovarian cancer would have at least 2 possible targeted options to manage or fix their mucinous ovarian cancer. That's very exciting. It's very early stage, but it's a big step forward than where we were even 5 years ago. So the second group I wanted to talk about tonight is the low-grade serous. So that again differentiates from the majority of women who have high-grade serous ovarian cancer. This is the group of low-grade serous tumours. The Australia and New Zealand Gynecology Oncology Group, known as ANZGOG, have helped investigators move forward on a study of women with low-grade serous and endometrioid types of ovarian cancer, as well as those who had recurrent borderline tumours. All of these tumours had expression of estrogen receptors on the surface of their cancer cells. These tumours are not usually responsive to chemotherapy, but they can quite often be a fairly slow growing, but over a number of years rather than over a number of months. Again, these cancers are not usually responsive to the platinum-based chemotherapies that are usually used in ovarian cancer, and they are not associated with BRCA mutations. So this study looked at the use of an oral anti-estrogen therapy called anastrozole and found a clinical benefit of around 64% of patients at 3 months, and in just under that at 6 months. This is a treatment that's really well tolerated by most patients, with the side effects very classically those of those anti-estrogen or menopausal type side effects. A third group that I wanted to talk about is clear cell ovarian cancer. So this is an ovarian cancer that's often associated with endometriosis, is more common in patients of Asian ethnicity, and in fact is often presented with a large early ovarian cancer that doesn't spread to other areas of the abdominal cavity. It really only represents a very small number of patients who have recurrent ovarian cancer. Often, if it is recurrent, it is less sensitive again to platinum-based chemotherapy. In the past, clear cell has always been put in together with other ovarian cancer trials, but very excitingly, Australia is going to be involved in a clear cell ovarian cancer trial looking at more targeted therapy at the genetic changes that occur in this type of ovarian cancer. Finally, I wanted to also look at endometriosis as another subpart of clear cell. So I have been involved in a study in Victoria looking at the genetic contribution. So this is whether we can discover genes that might be shared by women with endometriosis, where we know that there is around a 51% rate of other family members having endometriosis if one member of the family is identified as having endometriosis. We know that endometriosis affects up to 20% of women who are of reproductive age, and it's where these areas of what is normally contained within the lining of the uterus or womb seems to efflux out, probably through the fallopian tubes, into the abdominal cavity, can often cause problems with fertility, is often associated with very significant pelvic pain, particularly around period time, but is also associated with an increased risk of ovarian cancer. So we used around 600 patients from the Variants in Practice or VIP study that has been carried out in Victoria for women who have undergone genetic testing with a history of ovarian cancer who were not identified as having a BRCA genetic change. We found 25 patients who had ovarian cancer arising from an area of endometriosis, and we have searched extensively through their genetic material to come up with 14 possible genes that might relate to an increased risk of hereditary ovarian, but hereditary ovarian cancer related to a background of endometriosis. So further work is planned in this with a collaboration of a large group of endometriosis researchers from Melbourne and Queensland, as well as, again, international collaborators. I wanted to take a sideways step now and talk about genetic testing. So a term called treatment-focused genetic testing is where genetic testing is carried out for patients where a genetic change is likely to immediately change the treatment processes by either changing the surgical plan, whether radiotherapy is used or not used, or choices in systemic therapies like chemotherapies or targeted therapies. For women who have been found to have ovarian cancer in the setting of a BRCA change, PARP inhibitors have really changed their treatment options, particularly in the advanced or recurrent ovarian cancer setting. Of course, finding a genetic change in an individual who has ovarian cancer is not just about treatment-focused testing, but also about opening up predictive testing for their family members to see if other family members also have an increased risk for ovarian and the other cancers that might be associated with that genetic change. Genetic testing is now carried out in a panel of genes that can lead to an increased risk for ovarian cancer. But over the last few years, we have realized that it's not possible for all women to make their way from their home hospitals or treating team to a specialized genetic center to undergo genetic testing. But because we know that around 15 to 20% of patients who have ovarian cancer have an underlying genetic change in a hereditary cancer gene, and that this would influence the treatments that their home team would consider, but also importantly, it's about uncovering genetic susceptibility in their family members. So we've been involved in teaching healthcare providers of patients who are treated with ovarian cancer about how to provide genetic testing in their home centres. This is called mainstream testing. This is where the genetic test is provided in your home hospital, not in your actual home, but in your hospital by your healthcare team, and you're referred on to a family cancer centre only if a genetic change is found or if there's additional significant family history of cancers that it might also need to be explored by the family cancer centre. This means that there are fewer appointments for women and their family to have to attend, and particularly at a time where they might be undergoing significant chemotherapy or just have had surgery. It also means that results are getting back to our patients faster and to their treating doctors. The other big change that has happened in the last few years is that there is now Medicare rebate for people who have ovarian cancer under the age of 70 or at any age if there is some additional family history of cancers that would suggest a raised possibility. The alternate to a Medicare rebate is where the family cancer centre would fund the testing for women with ovarian cancer. There is also some new upcoming possibilities of actually doing genetic testing in tissue that may be stored. Why might this be useful? This might be useful for families who sadly have lost one of their family members to ovarian cancer in the recent past, where the actual gene testing might be able to be carried out on the tissue that still might be stored in the pathology laboratory. So while we know that PARP inhibitors, a targeted therapy for women who have BRCA changes, has been used in the setting of advanced or recurrent ovarian cancer, the recent SOLO 2 trial has been presented at the end of last year. This is where Lynparza or Olaparib is given to women following their primary chemotherapy just after their surgery, and has found very significant changes to lead to what will be a change in practice around the world for women who have BRCA-related ovarian cancer. So these women took maintenance Olaparib after they had completed their ovarian cancer-related surgery and chemotherapy, with now around 40% of women not having relapsed since they've completed their Olaparib treatment. This is really different. If you can look at that green curve there that tracks down towards the bottom of the screen, these are the women on the study who were taking a dummy or a placebo drug. The line across the red represents those women who were given Olaparib. This was a blinded study, so women weren't, or their treating team were not sure who was taking what. But this trial will absolutely change the treatments for women here in Australia who are discovered to have a BRCA change associated with their ovarian cancer. Sorry, the other thing about this trial is that you can see on the right-hand side, there's one hand that holds a handful of capsules. In the other hand, there are 4 tablets. So this was a trial that looked at the use of Olaparib in tablet form rather than capsule form, and has proven benefit with the capsule form and also tolerability amongst patients. So there is a move afoot in Australia for us to be able to utilise the tablet forms of treatment. I couldn't possibly do a talk without including some of the genetic changes that have also been found in the last few years. So if you have a look at this pie graph, the blue represents the number of women with hereditary ovarian cancer who have a change in the BRCA1 gene. So the vast majority of women who have hereditary ovarian cancer have a change in this gene, the second most common being the BRCA2 gene. But if you have a look in the pale blue section, you can see that there are a large number of other genes that have now been found to be associated with an increased risk for hereditary ovarian cancer. These can be grouped into several groups. The first group, group 1, RAD50, RAD51C, BARD1, PALB2, CHEK2 and NBN, are all associated with a state called homologous recombination deficiency. BRCA1 and BRCA2 are also genes associated with this deficiency. And PARP inhibitors, the treatment that I talked about associated with the SOLO2 trial, is something that takes advantage of this homologous recombination deficient state. So there is quite a possibility and quite a lot of excitement around the fact that there will be additional groups of women who might also have an advantage of taking Olaparib in the maintenance setting after their first line or in the recurrent setting. The second group of women are those who have mismatch repair genetic mutations identified, and there is growing understanding that immune-based therapy can effectively treat cancers that are occurring in the setting of this what's called mismatch repair deficiency. So again, a more treatment-focused basis to the possibility of treatment for their ovarian cancer. Ovarian cancer improvements cannot be achieved without significant collaborations between hospitals, ovarian cancer research cooperatives, universities, ovarian cancer interest groups, and study groups. Research can be pharmaceutical-led, it can be led by investigators, it can also have consumer drivers, but it also absolutely requires willing and brave patients and their support from their families. So thank you for listening, and I'm happy to take some questions at this time.
Thank you. Thank you very much, Dr. Antill, for that valuable presentation. We do have one question for you. If someone's asked, if I've had testing for the BRCA gene and it's come back negative, should I be getting testing for the other newer known genes that you mentioned?
Well, that's a really interesting question, Vanessa. I think it depends when the person had their ovarian cancer genetic testing, and also if there is any other family history of breast or ovarian cancer in their family. If the answer to that is yes, and particularly if the type of breast cancer is triple negative breast cancer, then yes, I think there would be a recommendation to consider going back and having a look at some of those other genes that are on the newer panel. But if a woman was older at her diagnosis of ovarian cancer and there is no other history of ovarian or other types of cancers, in particular breast cancers or triple negative breast cancers, then perhaps I think the genetic testing has been done as completely as it possibly should be.
Great, thank you. And just one more question. Are there any new treatment options for P53 gene changes?
Yes, I can see that there are a couple of questions about P53. The world is waiting for a treatment-focused targeted therapy for P53 changes. P53 changes are extremely common across a number of cancer groups. including high-grade serous ovarian cancer. P53 gene changes are often associated with a much more aggressive form of cancer, and I am very happy to say that there are some very early clinical trials that are starting to look at a treatment that might target P53 mutations associated cancers. These won't be all P53 mutations, they are a select type, but it's a start.
Fantastic. Well, we'll be looking out for newer treatments in that area. We'll leave it there, just looking at time. Thank you very much, Dr. Antill, for presenting and for giving up your time of an evening. It's very much appreciated.
Thanks very much for having me.
Okay, so I'm now extremely very happy to introduce our second speaker, Dr. Tarek Meniawy. I'll hand it over to you, Dr. Meniawy.
Thanks, Vanessa. Can everyone hear me? Hopefully that's a yes.
Yes,
and thanks to Ovarian Cancer Australia and to everyone who's attended this time in the evening. Hopefully I won't keep you too long or make this too dry. So there's a lot of kind of details and pictures in those slides, but what I wanted to try and go over is some of the latest developments in ovarian cancer in the last probably 3 or 4 years, and some of the potential directions that we may be headed towards. As Vanessa mentioned, I'm a medical oncologist based in WA. So really the outline is looking over latest developments in immunotherapy, looking at targeted therapies, some of the ongoing trials and the future direction. Immunotherapy for ovarian cancer is something that remains in early development. It remains something that is a promise. It's not yet something that's routinely available, but using the immune system overall has been something that we've been hoping to achieve for more than 150 years. When the first surgeon identified some immune cells in lymph nodes infiltrating tumors and therefore linking potentially immunity and fighting cancer. Fast forward 100 years, and we started developing theories about how the immune system can balance itself against cancer. And the 3 E's of immunity against cancer is either elimination, where there can be cancer cells, but the immune system is in control and has the upper hand and eliminates all the immune cells. This is something that can last quite a long period of time. On the other end of the spectrum, which is escape, that's when the tumor is growing and is not controlled by the immune system. So there's probably a state in the middle, which is the equilibrium, where there may be some tumor cells, but kept in check by the immune cells. And that can also happen for quite a period of time. I'm not going to go into detail in this slide, but just to show that there's very complex interactions between the different immune cells, things that we call checkpoints or immune checkpoints. These are signals or flags that different cells display to each other to either have an active response against the cancer or virus or infection, or to down play or suppress that response. And essentially, we've developed drugs that can target some of these regulatory pathways to try and target these immune checkpoints and stimulate a response. So one of the drugs and one of the number of drugs that has been developed, and the first to be approved in cancer, is called Epithelial or Yervoy, and that was the first drug used in melanoma as an immune targeting drug. Going back to ovarian cancer, it's been quite a long time. It's probably more than 15 years that we've recognized a relationship between immunity and immune cells and ovarian cancer. And on this slide, essentially, is just demonstrating how tumors that have immune cells can be kept in control for much longer and for a higher degree of destruction by the immune system compared to those that don't have immune cells within them, suggesting that perhaps if we have a way of activating and bringing in these immune cells into the tumor, then we can achieve this extended, better and longer outcome than without having these cells. And indeed, the first trials of immunotherapy looked at one of the common immunotherapies that's now used in melanoma and lung cancer, and this is called nivolumab. And even this was a very, very small clinical trial that had 20 patients having 2 different doses of this drug. And these lines represent tumor shrinkage. So anything below 0 is a reduction in size of tumors. And this is the duration of how long that was held. So that's more than a year of some of these tumors reaching almost minus 100%, which means disappearing. So small numbers, but show that when immunotherapy works, and long after it was finished, which is usually just the first 2-3 months, then there can still be a long-lasting control that otherwise is not seen with other therapies. The trials that we have seen so far in ovarian cancer are predominantly in ovarian cancer that has recurred rather than just diagnosed. And there's quite a number of trials here. And this is the phase of the trial. And early phase trials are phase 1, phase 2 have larger numbers, and phase 3 are the bigger trials that lead to drug approvals. And you can see that all of these are just phase 1 and 2, so small numbers. And on the right, it shows the chance of the drug working. So these percentages are response. So what proportion of patients this worked. And mostly the numbers have been quite modest when the cancer has already recurred. But in the last few months, there's been 2 trials pushing up that likelihood, going up to almost half of patients had a benefit of getting immune therapy when it was combined with chemo. And another trial showed that a third of patients, 31%, got a benefit when 2 immunotherapy drugs were used instead of 1. Just change the pointer here. And this is just highlighting that one of those last slides, which essentially had recurrent ovarian cancer, tried either 1 immune therapy drug or 2 for 4 cycles, so 4 cycles 3 weeks apart, followed by the 1 drug only. And as I said, the response rate in this trial was about a third, so 31% of patients got a benefit. More recently, in the last 2 to 3 years, been launched a number of immune therapy trials in ovarian cancer that has just been diagnosed. So women that have typically had a stage 3, which is the most common stage of ovarian cancer, will receive typically the standard proven chemotherapy, but adding some immunotherapy agents to it. And there's no formal results from any of these trials, but you can see here that there's 5,000 to 6,000 patients from these and the previous trials undergoing these new experimental treatments, and hopefully this will result in some successes in newly diagnosed ovarian cancer. Again, trying to invest in the fact that if we can get the immune system to do the job, that can potentially last a lot longer than chemotherapy only. So I think these 2 slides were the wrong way around. So that's just the previous trial and showing that 33% response in combination drugs compared to the 12% response in single drug immunotherapy is one example. Well, the ongoing trials, I've listed some of them, but this is an example of one trial that's running in Australia, and it's running in most states. It's called iPrime, and it's looking at women with newly diagnosed ovarian cancer and having chemotherapy with 2 different immune therapy drugs, and comparing that to the standard chemotherapy, 3 cycles, and surgery, and a further 3 cycles, and then going on to immunotherapy for another 9 cycles, so about 7 months. And that trial is ongoing in Queensland, New South Wales, Victoria, and WA. These are the states that it's running in. And hopefully that will be really the first trial to use combination immunotherapy with chemo in the first line in the first newly diagnosed ovarian cancer. Another trial that's completed, and we're waiting for the results to be presented, was also newly diagnosed, looking at chemotherapy alone compared to chemotherapy followed by this immunotherapy drug called Epithelial. And the third group receives chemotherapy with the immunotherapy followed by the immunotherapy. We're probably expecting results from this trial later on this year. So just stepping back from immunotherapy and going to target therapies for a few minutes. Targeted therapies in cancer in general are those that are targeting a particular pathway. So if we identify a marker or a signal on the cell that we want to attack, these were the people that developed these targeted agents, these antibodies that are created, manufactured to attach to a specific marker on a cell, which makes it much more accurate in identifying and attacking the cell than chemotherapy, which is more crude and affects cancer cells plus other cells at the same time. So this was really a suite of new drugs in lymphoma, in breast cancer, in leukemia, and more recently in ovarian cancer. And we've heard Vicki's amazing story with Olaparib. And these are essentially what we are hoping are the magic bullets against cancer, provided that we identify the target, and in this case, it is the BRCA mutation. Then these drugs can have pretty impressive benefits, which can, in some cases, last also for a long period of time. And therefore, back to the BRCA gene, and this was just the years 1990 and 1994, when the BRCA1 and BRCA gene abnormalities were first identified, and it took us, another 10 years or so before the first drug targeting this pathway called the PARP inhibitor, and that was Olaparib again, which is what one we just heard about, and compared to women that did not have Olaparib. So again, the top curve is showing when patients are not progressing, or as the curve drops, so suggesting that treatment is not working anymore, and there's a big improvement between having nothing, placebo, and having Olaparib. And when we focus on women that had the BRCA mutation, the gap was even bigger. So this difference is almost 3 times as good when you have the PARP inhibitor Olaparib with a mutation compared to having placebo with a mutation. So these drugs don't work as well in women that don't have the BRCA mutation, which is about 16-18% of women. There's another 6 to 8% of women that may have the mutation in the tumor but not passing it down in the gene. So almost a quarter of women may have this BRCA mutation in the gene, and this drug could be beneficial. And this is really a radical improvement in the treatment of ovarian cancer. We'll come back to that again in a couple of slides. So this trial was repeated and confirming that when the recurrent ovarian cancer has a BRCA gene and a given Olaparib, there is 0.3 is essentially a third, reducing by a third, well, reducing by 2/3, so remaining only 1/3 the risk of the disease progressing. This slide is very, very busy, but it's really what's trying to say is, in addition to the BRCA mutations, BRCA are genes that are targeting repair of DNA, how to repair our genes when they get damaged, and they get damaged every day, but they get repaired. And the BRCA, these 4 bits here, are genes that are responsible for repair. When they're defective, we're not repairing very well. There's another bunch of genes, another abnormality, where our ability to repair our DNA is also reduced, and therefore these drugs, PARP inhibitors, such as Olaparib, can also work in these remaining women. So instead of just being 1/4, it may be that up to 50% of women with this high-grade serous ovarian cancer that may potentially benefit from these drugs. And indeed, this was shown in another trial, showing that even in women that don't have the BRCA gene, that have recurrent, that sort of chemotherapy-sensitive disease, then these PARP inhibitor drugs can also be effective. So where did we go from there? So we talked about recurrent ovarian cancer and using these amazing new targeted treatments. we said, okay, can we use these earlier? Can we use these PARP inhibitors like Olaparib in the first line, as soon as the cancer is diagnosed? Is it better to use it early? And the SOLO-1 is the first trial to give us a result, and that was looking at Olaparib versus placebo if there is a known PRCA mutation, and we're awaiting results from these trials. Probably one or two of these will also be released this year. For Olaparib, this is a publication from late last year. Newly diagnosed women with BRCA gene and advanced ovarian cancer getting Olaparib. This is now not just tripling but quadrupling the delay in cancer recurrence, provided that there was that BRCA abnormality, either in the tumor or hereditary. So as of about 6 to 8 weeks ago, the FDA in America has approved this drug in women with ovarian cancer diagnosed and have a BRCA gene. And in Australia, this drug is now becoming available on an access program, and I'm sure will eventually also come to the PBS. So these PARP inhibitors like Olaparib are approved worldwide. In Australia, we have Olaparib in recurrent disease, but it's coming in new diagnoses as well. And there's other PARP inhibitors that are approved elsewhere in the world and probably also coming to Australia eventually. So this is the journey of these PARP inhibitors, these new targeted drugs, from the first activity in the lab, to early trials, to the approval of Olaparib in Australia and overseas, to the latest information on not just BRCA, but non-BRCA ovarian cancer, potentially also getting benefit from these targeted drugs. So how these things differ? So we talked in this, we heard already a bit about chemotherapy and targeted therapies and immunotherapy. They're all different in how they work. They're all different in how much side effects they have. So chemotherapy is we established very effective and still very useful for treating ovarian cancer. But these targeted therapies don't have the conventional side effects of chemotherapy. They may have slightly different things, whether it's rash or nausea or other effects on other organs. Immunotherapy is immune stimulating, not immune suppressive, but can also have specific side effects to immunotherapy like rash, inflammation of the bowel or lung or other glands. So you see a wide range of unintended effects of immunotherapy, but by and large, these are very manageable in experienced hands of clinical trials or as these drugs become more widely used. So what does the future hold? We need to consolidate some of this information. How do we bring together what we've now discovered in parallel, BRCA genes, alterations in other genes in ovarian cancer? Immunotherapy probably works. We need to find when to use it, how to use it, what to combine it with. So we need to discover the barriers, why immunotherapy doesn't work, drill down on the cells, the lymph nodes, the blood. And we're trying to collect a lot of samples from generous patients that are joining these trials to learn a bit more about who's going to benefit and who won't, so we can prevent toxicity and prevent the use of things that won't be effective. And trying to look at all these different checkpoints, these other signals that perhaps need to be combined with sequenced in different ways to better improve the interaction between the tumor cells and the immune system. So one of the concepts that we recently discussed at a national meeting was integrating immune therapy, chemotherapy, and Olaparib. We're trying to work out how do we integrate immune therapy and chemotherapy in women with newly diagnosed ovarian cancer, and that is a concept that we're hopefully going to take internationally in the coming months. And if this moves forward, then it may very well be a trial that comes to Australia, following on from the previous IFRIME trial in the next 12 months or so. And we're trying to move away, therefore, from empirical medicine. We're using the same chemotherapy drugs again and again for everyone, which remain an important component of treating ovarian cancer. We're trying to better divide patients to, okay, you have a BRCA abnormality, you don't have a BRCA in the blood, but you have a tumor. So you don't have a BRCA, but you have something like BRCA that may make one sensitive to a particular target, to dividing things into groups, then personalize where each individual will be matched to the most suitable treatment that they are more likely to benefit from. The take-home message really is that we've had several breakthroughs, and I only gave a very, very brief touch on two of these, in targeted therapy and immunotherapy. In the last 3 years alone, there's been several breakthroughs. I think survival in ovarian cancer is changing. It's changing, and it's changing now, and it's changing purely, if anything, based on the impact on BRCA-related, or even some of the non-BRCA-related, but similar to BRCA with these new targeted therapies. We're hoping to see some more information about immunotherapy in the coming couple of months, but certainly years, and it definitely would not be possible without the generous contribution, time, risk that Vicki and many of the other patients that participated in these trials, not just to get a benefit, but to provide knowledge that's going to advance and improve outcomes for the next patient that has to go through it. That's really all that I have. So thank you again for your time, and happy to take some questions.
Well, thank you so much, Dr. Tarek Meniawy, for that very informative presentation. And wow, all this research and the latest developments are just so promising and so exciting for women with ovarian cancer. So thank you. I know we've gone over time, so I do apologise, but just a couple of questions have been posted. One, we've had a few people asking for access to the slides. All the presentations will be uploaded onto our website, to the Ovarian Cancer Australia website, in the next couple of weeks. And in the next few days, you will receive an email with a link to the recording of the entire webinar. Just a question for you, Dr. Meniawy. How do we gain access to some of these trials that you've spoken about? And one specifically, which hospital in WA are some of the trials happening in?
Sorry, I had myself on mute, sorry. It can be very overwhelming, knowing that there's such a wide range of targets, mutations, abnormalities, and potential trials, and how to seek them. So it's probably always a good first point of contact to speak to your oncologist. They will hopefully be connected with other experts in ovarian cancer, and if they don't know where the trials may be, at least they will hopefully know who to contact to ask where targets may be, or where there may be opinions about particular trials that may be available, just like Vicki has done. So your oncologist, your surgeon, your gynae-oncologist, and potentially your GP would be the first contact to help you navigate how to get to the research centers and where the trials are occurring. Specifically for immunotherapy trials in WA, the first-line trial, the ovarian cancer trial that's running at St. Giles Gardner Hospital in clinical research, as well as St. John of Subiaco, but there's also other trials in recurrent ovarian cancer running predominantly probably at these two hospitals. But most oncologists and surgeons that treat ovarian cancer in the state will be able to point you in the right direction, depending on your particular circumstances.
Thank you. And just, well, I've got time for one last question. Is it true that if one immunotherapy drug didn't work, that none of them will work, even in combination?
No, it's not necessarily. It's quite a broad question. It just depends on the cancer and individual circumstances. But each of these immunotherapy drugs is going after a specific target. And at the moment, we don't have tests to identify which target we should be hitting. So when a PD-1 target is not effective, it could very well be that what was needed is a CTLA-4 target, just the molecule next door. And there are lots of trials in other cancers that demonstrate after one immunotherapy doesn't work, you combine two different immunotherapies, or even just a different immunotherapy drug that might work. So it's not a blanket rule. It might generally tell it's a bit more tricky for that to respond to immunotherapy, but it doesn't mean it's not absolute.
Great. Okay, well, thank you so much again, Dr. Meniawy. We will let you go, but thank you so much for your time and your valuable, very informative and valuable presentation.
You're welcome. Thank you for having me, and thank you, everyone.
All right, so I'll introduce our third speaker. Vicki was going to speak last, but while we're waiting for Dr. Meniawy, I'm extremely excited to introduce this wonderful lady to you and her beautiful daughter. This is Vicki and her daughter Angela. So I'll hand it over to both of you.
Okay, thanks, Vanessa. Thanks, everybody, for joining us. I was diagnosed in November 2013 with the high-grade serous epithelial cancer stage 4. And initially, I thought it was my irritable bowel because I'd had that since I'd had my last baby. And I even rang up the gastroenterologist and he said, oh, maybe you need to go on the FODMAP diet. Anyway, the symptoms sort of increased and my stomach swelled up like I was about 4 months pregnant. I had a little bit of nausea. I was wanting to urinate more frequently. I was lethargic. I was a shift worker and I kind of put down some of those things to those symptoms. But when my stomach swelled up and I went to put my uniform pants on in the morning and I thought, oh my gosh, there's more to this. So I went to the doctor, I got a referral, I got a CA125 blood test and I got a transvaginal ultrasound which had a good look into the ovaries. It's a probe that they insert into the vagina and they can have a really good look at the ovaries as opposed to just doing a normal ultrasound. Now then they discovered I had the cancer on the left ovary. I had 1.5 litres of fluid in my right lung. I had nodules on my liver and the fluid. So then I had to go and have the fluid drained off prior to surgery. I had the debulking surgery. I also had the omentum removed, which is the breeding ground for cancer. And the professors that did the surgery thought this would be a good preventative measure because even though there was no cancer in the omentum, it can still be a breeding ground. So that was taken out. Then I had 18 weeks of chemotherapy, carboplatin and paclitaxel. I had a bit of a hiccup along the way with having had one blood transfusion, but everything came back to normal. And then at the end of that, I kept on, at the beginning and the end, I kept asking my oncologist, could I go on a drug trial? And she said, well, first of all, you need to have chemotherapy before you do anything to get rid of this cancer. So at the end of the 18 weeks, my CA125 went down to 24 from 900. Originally, it was diagnosed, it was 900, the CA125 went down to 24. And then I said to my oncologist, can I go on a drug trial? She said, well, look, I'll refer you to Professor, but I'm not aware there are any trials going at the moment. So about 3 weeks after I finished treatment, I got a phone call from my oncologist and she said, Vicki, you're still interested in this trial? And I said, yes. So she said, well, can you get down to the Women's Hospital this week? They need to run scans, blood tests, etc., see if you fit the criteria. So we went to the Women's Hospital. I had CT, chest, abdominal, pelvic scan. I had blood tests and all this sort of thing. And also I do have BRCA1 and BRCA2 mutation as also a pass to my daughter, unfortunately. So then the professor said, well, look, you need to read this document. It was a 28-page document. And it tells you what side effects you may have, how it may affect you. And then if you agree with all this and you agree to commit to going to monthly appointments, taking the medication, having the CT scans and the blood tests and everything to monitor along the way. And maybe sometimes you do have to travel because we live on the Central Coast and we travel into Sydney. And if you're committed to doing all that, and I'll go for it because with the high-grade serous epithelial cancer, if you rely wholly and solely on chemotherapy, then eventually it becomes resistant and it no longer works. So you need to look outside the box. You need to look at drug trials, and they're just working wonders with so many women, as you've just heard. And I really see it as a way moving forward, and it's the only way, because I did have a cousin. She had ovarian cancer. This was over 16 years ago now, and she had to rely wholly and solely on chemo, and unfortunately she passed away. So I'm really encouraging people to get out there, push. You need to push for the drug trial. You don't necessarily get it given to you. You have to push for it and say, I want to do it. Keep ringing up, doing research on the computer. There's an app now you can get to search for drug trials. Just keep asking, and it depends on the time frame, because I was so lucky. It was only like 3 days that I had to get into this drug trial, and I made it because I matched the criteria. I agreed to commit to it, and I've been very positive all the way along. At the beginning of the drug trial, I did get a bit of nausea. My hemoglobin did go down a little bit. Even though we didn't know if I was on sugar tablet or the real tablet, Professor said, look, your symptoms he doesn't even know either what it is. And he said, look, if you can persevere after about 6 weeks, symptoms should settle down. So that's exactly what I did. I persevered and everything's just settled down. Now I can just say I have some fatigue, but I managed that through exercise, a good diet, and resting when necessary. I may have to have a rest in the afternoon, just lay down for an hour or so. I don't actually go to sleep. I might read a book or watch TV or do meditation or something like that. Also, I go for a walk on the beach every morning. That's all part of it, because with the drug trial, you have to look after your whole body. You have to look after your diet and everything. You can't just take a drug trial and think, oh, good, I can drink, I can do this, I can do that. I don't drink or smoke or do any of those things, but I would advise people, if they were serious about the drug trial, just to stick to a healthy diet and try to be as healthy as possible for it to work. I guess have a look if there's anything else I need to say. So going on this trial, for me, it's been hope. Like, it's taken away a lot of anxiety, because I know that so far I've gone really well with the trial. I haven't had a reoccurrence, and it's been a very, very positive outcome for me. So as I say, I advise any woman to look out there for drug trials, because my experience has been so positive. And if I didn't have that, I would have so much anxiety, it wouldn't be funny. So it's just a matter of stepping outside the circle, outside the square. I have a lot of friends who were in my ovarian cancer group, but they mainly just stuck to chemotherapy, and that didn't work out for them. And they were too frightened to go on the drug trial. They were so fear of the unknown and all this sort of stuff, and side effects and everything like that. But I basically said to my husband, look, I'm a stage 4 anyway, so what have I got to lose? And he agreed. And the big thing with drug trials is you need to have your partner, your family support you on it too. And my husband was so very supportive, where sometimes ladies, husbands, they don't want to go on it. They think it's going to do something terrible, or it's not going to work, or something like that. You just have to be willing to put yourself out there. And I'm so glad I did. And you do need that support around with family, though. That makes a big difference. But the whole reason I went on the drug trial was to extend my life. And the thing is that the longer you can go without having chemotherapy, then the more you extend your life, because if you just rely solely on then you might get a recurrence back in 6 or 12 months or 2 years, and then it will become more frequent. But if you can extend that time period between chemotherapy and not having it, maybe you can spend it for 2 or 3 years or more, then when you have to go back to chemotherapy, it's going to work. It's going to be more effective. If you haven't had it for 3 years, so your body's sort of it's gone out of the system. So that's how it works. It will extend your life, and the longer it goes on extending your life on the drug trial, then the less likely you are to have that reoccurrence. So I can only say positive about it. I think that's really all. I wanted to let my daughter Angela just say how she felt about me going on the trial.
Hi everyone. Well, I guess for me, I guess the big call out is that Mum's here. So when Mum was diagnosed 6 years ago, after the first sort of few months, I didn't think that I would even have a mum, sort of at this time. I remember making deals with the devil, just begging to have my mum here, even to reach her 60th birthday. And we're going to be celebrating that this Sunday. But, yeah. So I guess for us, my mum's my best friend. She's everything to me, and she is like a second mother to my 4 children. And so seeing my mum in a really vulnerable state and not being really well was really difficult. And I guess having this, or her being accepted into the drug trial is just like a lifeline. It's like a phone a friend. It gave us hope. And I think for Mum, it wasn't just that she was, going to be on this drug trial, but I think mentally just being accepted into it, because it was a little bit of a challenge, and it was her knocking on doors and constantly asking questions and asking if she was suitable and if there was anything available. So for her to be accepted, that was the first big tick, and I think mentally that just really got her in the right headspace. And then obviously the medication and the fantastic medical team and things like that sort of allowed her body to receive the drug well, or we think it's the right drug. So she's still here, and she's healthy, and we're just really appreciative of it. So I'm just really grateful that my mum was one of those types of people that just asked further questions and just asked what else was available out there, because it means that I still have my mum, and still my best mate, and the kids still have mum as well. Yes, so that's all. That's all.
Well, thank you both so much for giving up your time. I know you're on holiday, and yes, celebrating Vicky's 60th. Happy birthday, Vicky. We hope you have a wonderful week. Just wonderful to see you looking just so well, and yeah, happy birthday for this weekend. Just before you go, someone has written, thanks so much, Vicky. Hearing your experience has been very helpful. Wishing you so much health and happiness in the future. That was from someone called Nicole, so thanks, Nicole. Mark has asked what drug is Vicki on, with Olaparib. And just another question, Vicki, you mentioned an app that lists some clinical trials. Do you know the name of that app?
Yeah, it's I'll just have to look on my phone. I can actually email it to you if you want. My oncology nurse actually emailed it to me, or she texted it to me, and I've got it on the front of my phone. And it's Clinical Trial Refer Oncology New South Wales. That I can send it to you also. That it's really good. All you do is put in your search, what you're searching for, ovarian cancer, and it shows you all the hospitals that are doing trials at the moment. And
is that just for New South Wales? Is that just in New South Wales?
Yeah, that's for New South Wales, but there are other, like Melbourne and that, I think they've got their own app. This is a New South Wales one. Also, there's one for breast cancer trials as well. And it's an app, but I can send it through to you, but I think every state has probably got their own clinical trial searching tool.
Right, so what was it?
Great.
Okay, it was called Refer?
It's called CLIN trial, so CLIN trial, refer Oncology New South Wales.
Okay, fantastic.
And that's general
Great.
participants for all cancers. Or,
You've been able to find a trial for one of our relatives just recently on there. So.
Hooray, sister. So she had metastatic breast cancer, and I've found trials at St Vincent's and at the Anne at Woonga, and she's actually going there this week. So, yeah.
Fantastic. Well, thank you so much again. We won't give up any more of your time. We really appreciate it. And once again, a big happy birthday, Vicki. We hope you have a wonderful week.
Thank you.
Make it the year. Make it a birthday year.
Yeah.
Big year celebration. So once again, I'd just like to say a big thank you to our speakers, Dr. Yoland Antill, Dr. Tarek Meniawy, and Vicki Sidoti. We really appreciate the information that you have shared and the time that you've given us this evening. Thank you everyone for being on the webinar. We really hope that you found it valuable. Like I said earlier, the recording will be posted on the Ovarian Cancer Australia website in the next couple of weeks, and you will receive an email with a link to the recording of the webinar in the next few days. If you have any other questions that you would like addressed, please don't hesitate to contact our information and support line on 1300 660 334. So thank you again, everyone, for joining the webinar. We hope to see you for our next webinar in June, which will be on genetics and ovarian cancer. Enjoy your evening. Goodbye.